Hello, everyone. Welcome to today's learning event. We're giving everyone just a little bit of time to come in. But welcome to today's webinar, Engaging Consumers in Mental Health Care. My name is Emily Moore. I'm one of the project managers at the Southeast MHTTC, and I'm going to be moderating today's learning event. And as people are coming in, I'm just going to give a little bit of information about our center and a little bit of housekeeping information before I turn it over to Dr. Rollins and we get started. Just want to let everyone know that the work of our center is sponsored by a grant from the Substance Abuse and Mental Health Services Administration, or SAMHSA. And also just want to remind everyone that our center, as well as the larger MHTTC network, uses affirming, respectful, and recovery-oriented language in all of our activities. And I encourage all of you to use similar language as you're speaking in groups and chatting in the chat. A little bit about our center. We are the Southeast MHTTC, and we are proud to serve the 8 states in HHS Region 4. And we have the unique opportunity of being able to address public or mental health priorities through a public health lens. I encourage all of you to visit our website to learn more about our upcoming training opportunities and resources and events like this one. I'll give a little bit of housekeeping information before we start today's event. Just so you know, parts of this, not all of it, but parts of this event are being recorded and might be posted on our website later for on-demand viewing. Typically, that happens within about 72 hours. We encourage everybody to share your thoughts using the chat feature at the bottom of your screen. And remember that while our presenter is talking, please keep yourself on mute so that everybody can hear. And then usually we devote time at the end of our presentation for the presenter to answer questions, but I think that Dr. Rollins is going to be monitoring the chat and pausing throughout to address questions that are posted in either the chat or in the Q&A feature. So just be on the lookout for that. And then at the very end of today's learning event, we are going to have an evaluation survey that's going to be shared in the chat. And if you are interested in downloading a certificate of attendance, then you will have to fill out that SAMHSA required evaluation survey in order to download your certificate of attendance afterwards. And of course, if you have any questions, please just feel free to contact us at info@southeastmhttc.org. All right, I'm going to take a minute to introduce today's speaker. Angela Rollins, PhD, is a research scientist at Regenstrief Institute and Associate Research Professor of Psychology at Indiana University, Purdue University, Indianapolis. Dr. Rollins' research interests are primarily in studying methods for improving implementation and evidence-based mental health practices for people with severe mental illness. Recent topics include the measurement of program fidelity, improving clinical knowledge and skills, and reducing staff burnout. Clinical populations of interest include those experiencing homelessness, mental illness, and/or co-occurring substance use disorders, as well as populations that might best be served by mental health and substance abuse services integrated within primary care settings. Dr. Rollins has particular expertise in the implementation of assertive community treatment, illness management and recovery, supported employment, and integrated dual disorders treatment. Thank you so much for being with us today, Dr. Rollins, and I'm going to go ahead and turn it over to you.
Right. Thanks, Emily and Stephanie. Welcome, everyone. Let me figure out. I've got all the screens. I have chat over here, so I can kind of keep an eye on it. I've tried to re-angle, so that's a little bit better. Let me get my slides up and going. All right. We think we made it. So welcome, everybody. Really happy to have you here and be talking about this very, very essential idea that we have to work to really engage many of our clients. So let's see what we have here. Okay, I moved you all. Hold on. I moved you all down to where I can't do the buttons. All right. So I am not wearing my VA hat today, but I do have to say that I'm there are times when I do put on a VA hat as a mental health services researcher. And so nothing I'm presenting here, it's all my experience in this field, and they do not, what I'm saying here doesn't represent the views of the VA or the government. So it's very important that I mention that. No other disclosures. So first off, let's start with a poll to sort of warm things up. And now I've moved you all over here, so apologies as I have to look away. All right, I have stored the polls. So we're going to think about our consumers who first get assigned to you and your team. I'm going to ask you to respond here. All right. So think about the consumers when they first get assigned to you or your team. How many of those consumers were actively engaged in services at the time that they were enrolled? So go ahead and give us your poll responses. Ooh. Oh, nice even spread here. I'll give it a little bit more time. I think we're pretty close. Okay. So I'm going to go ahead and end the poll now. Hopefully everyone's had a chance. And we'll share the results. So it looks like kind of in the middle. We've got, that's actually a really nice distribution. So there's a set of you who are, less than a quarter of your clients are engaged at the time that they're enrolled. The biggest group is in this 25 to 50% of the clients are engaged. And then a few that are, it looks like less than half are 50%, have 50% or more of their clients are engaged. So a nice spread, but certainly a big chunk of our clients when they first come to us are not engaged. Wonderful. All right, so let's go back. All right, so nice spread. So when we think about the struggles for engaging consumers with mental health concerns, everyone is on the same page. It's not always easy. So in thinking about this topic, like how do we best support the engagement of the consumers that we serve? There was a part of me that thinks there's a whole range of skill sets that are common across many different types of programs or practices that we just, and many of them are not new skill sets to think about, but certainly when you are busy, you have a lot to do, you have a lot on your plate, these are skill sets that sometimes we have to really think and strategically set aside time to really practice those skill sets and implement those skill sets. And then the last part of my presentation, I want to talk about not just what an individual clinician can do or how they think about serving their consumers, but what are the programmatic characteristics that assertive community treatment, which is something that I'm really invested in, that approach and other approaches like it. But what program characteristics really support engagement? So in terms of program principles, team roles, those sorts of things. So that's sort of how we're going to divide our time, at least in the first hour, sort of talking about these topics. So let's launch in. This one is not necessarily a poll, but I think it is fun to have people write into the chat their responses. And I think someone, a colleague of mine refers to it as like a cascade of responses. So I want you to think of some of your consumers and tell me, what does it look like when the consumer is engaged? But try not to type it into the chat, but don't hit enter until I give you the signal, and then everything will come out all at once. So think about the consumer who is engaged. What does that look like typically? I'll pause here for a minute. All right, if people have had a chance, why don't you go ahead and hit enter and give us a, ooh, yay. Okay, got a few responses. Keep them coming if you have them. So I see, ooh, I'm losing the top responses here. So Audrey says asking questions and responding, expressing interest. I love that. Compliant with medication. That's another way to think about it. Asking questions comes up again, wants to improve. I love that. Setting goals, attending sessions, following through on the things that they need to do. Kelsey says consistently coming to appointments and doing the work. I mean, it's difficult to make changes in ourselves. So that certainly is a sign of engagement. They're responsive to suggestions. Lisa says when someone is engaged, they participate in the session. Active listening, client interactions, you see changes in behavior, actively participating. Consumers are engaged or punctual. Let's see, actively working on goals, showing up, giving it a try. Let's see, they participate and they want to get better, feeling accountable. Great responses. So that's definitely the, many of the types of things that we're looking for in this. So hopefully that gives you some ideas of what the end goal is for our talk today. So let's talk a little bit about some of the principles of engagement. Now, and I can see where this first half, I'm really talking about the clinician and the clinical skills. And so I can see where someone would say, why is it on me, to be motivated? Why isn't it on the consumer? And that's a great point. And it is change that happens with a mental health condition is certainly still the responsibility of the consumer. But the way I think about engagement is we only have control over ourselves. Even as clinicians, you all are bright, capable, well-trained people. But ultimately, and I mean, anyone who's parented can say this as well, is that we really only control ourselves. And so what you have control over as a clinician is your own mindset. So thinking about, do you have sort of predetermined beliefs about your consumers? Do you have biases about whether or not change can happen? So we want to really sort of, I always like to use the phrase, suspend your disbelief. Like change does happen. Sometimes it comes from unexpected places, and just being open that change can happen. It may not come in the timeline that we would really be most comfortable with, but it can come. Trying to be as non-judgmental as possible, being creative in thinking about how we conceptualize where the consumer is in terms of their goals and what they want to do and what really matches their strengths. So that sometimes like the sorts of things that we listed out before are maybe our ideal for what a client is, but we may have to think creatively about what motivation really looks like for our particular consumers. Another principle of engagement is that the sense of authenticity, that we are really genuinely curious and interested in the views of our consumers, and that the second that you're faking it, most consumers can figure that out and call us on it for sure. And being flexible. I think that's probably one of the biggest principles that I think about when I think about engagement, is that we may not be able to put every consumer into the nice, neat box. A lot of our consumers aren't going to show up for a 50-minute session once a week. And so how else can we think about scheduling or structuring services, structuring the time that we do have with them, and being somewhat flexible in in both our goals and our methods that we are using to work with our clients. So a lot of principles. So these are sort of the high level principles that I think about when I think about engagement. Yeah, and feel free if you have, I think that Emily had mentioned it. If you do have questions, go ahead and put those into the chat as we go. If you have questions or comments as we go, I'm going to try really hard to keep an eye over here to my left and see if things pop up. And I've tried not to overload with a ton of slides so that we have a little bit of time for interaction and see how that goes. But definitely put those into the chat for now, or and if we get to a nice pause midway through these topics, we'll pause and then I'll give you a chance to unmic and ask questions as well. So hopefully that works well for everybody. All right, so one of the first things that we might think about with how do we use different skill sets that really embody those principles. And so one of the things that I think about quite often is mindfulness. And mindfulness, of course, it's something that we want to teach to a lot of our consumers. It's really helpful from a mental health perspective. But I also think about mindfulness in terms of being in the right mindset to really engage with someone, to really be ready to interact with that client. And so this comes up a lot. I do a lot of burnout work as well with clinicians. And I think this notion of mindfulness and just sort of focusing on one task at a time. And I think in today's mental health world, it is tough to do this because, you have your productivity standards, you have all the documentation to keep up with, paperwork. And so really being able to say, okay, I have a client in front of me right now. Am I in the right place, to really start this visit and really be able to focus on that consumer and what it is that I'm going to hear from them. And so we really have to get out of that. As many barriers as there are in the mental health world to really embracing this approach, really sort of resisting it being one more contact that meets your productivity standard, and really focus on this as a person. And I think there are, within a given day, it's easier to have this mindset than others, but certainly sort of reminding yourself. And in our burnout work, we'll often talk about taking a deep breath before you answer that phone call, having a mantra before you walk through the door with a client that is notoriously challenging in some way, so that you say, you know what, I'm going to do the best that I can. Let's see. So these are things that are not new, certainly. And I know you've heard about mindfulness before, but the hard part is remembering to sort of go back to these basic concepts and being with the client in that right mindset and having that mindfulness before you sit down with the client. And so I think, being mindful, being ready for that contact that you do have with a client and being able to engage them, I think it really involves slowing down a lot. And that's when you are able to slow down, you're able to be present with the client, not have all the other to-do lists running through your head, be a little bit more patient when it's perhaps more difficult for them to articulate the kinds of goals that they want. Maybe knowing exactly what they want and being ready to change is something that we're striving for, but maybe that this particular client isn't there yet. I always think, making sure that we are able to still be genuinely curious about our clients. It helps us to listen more and just see our goal as really learning about this person, this human, their life experiences. And making our primary mission is to listen and hear, especially on the front end of our services with someone when we're just getting to know them. That there really is no replacement for that. And I always say, you have a lot of knowledge, the sorts of things that this consumer probably needs to do to get better and to reach their goals. But you have to invest in the listening and hearing before you will recoup the gain of being able to talk and be heard by that client later on. And so if you just think about listening and hearing and slowing down as an investment you're making into this relationship, that then is going to pay dividends later on when the going gets tough, when you ask them, when you really get into the active stages of treatment and they have homework to do to get better or to reach a goal, then you've got that social capital that you've built with a client to really have that relationship where, you help them, you challenge them, you ask more of them later on. And then also to think about this sort of slowing down, being present, being curious, being mindful as something that you're modeling for the consumer that you're working with as well. And so that's going to pay dividends for them. So it's, not only helping you to really engage this person, to establish that long-term relationship, but it's also going to model how they can connect to other people, which we all know that social relationships and social skills deficits are rampant in the clients that we serve. And so that's something that we have to think about. Let's see here. So I'll move on. The other thing that is not rocket science or the first time you've ever heard of it, but I want you to think about person-centered treatment planning, person-centered assessment, as these are important things that really sort of help you to understand the consumer, to understand what it is that their goals are, and helping them to tease apart the objectives. And so really being able to have that initial conversation, understand their motivations, their strengths, what they want. And then here's the kicker for engaging people in services. We have to be able to connect the services that we would like to offer this consumer to the personal recovery goals that that person has. And so, that's where you really do that's the marketing, basically. For mental health treatment is saying that this person wants certain goals and that you have services that you can really help to connect them. And that's something that hopefully will build their motivation to return and continue treatment with you, and whatever that looks like. And then also, I also wanted to mention too that, any kind of assessment or treatment planning, we can't think of it as static. I definitely have worked with a couple of assertive community treatment teams where it's like they did the intake with an ACT consumer who had, let's say the person was homeless. And, their primary goal was around getting housing. They didn't really think about having a job at that point. But then once they get housed, they're there for a year, they're still being served by the ACT team, their recovery goals changed. They'd like to try to get a job, so that was something that they weren't interested in back in 2022 in the beginning of it. But now they're getting to a more sort of stable point with their housing. They've met that goal. They're ready to go on and have another goal. And so sometimes I'll work with teams that sort of don't want to give up the initial goals. And so making sure that we're progressing, that we're evolving in terms of the types of goals that we're helping clients with as their goals change and as they get better. So hopefully there's always a new challenge ahead that we can help a client with. And then I don't want to talk, spend a ton of time talking about these, but just I put them up here for reference in case you look at these slides later. So, we're not necessarily talking about the traditional treatment planning goals, verbalizing understanding about illness, interacting appropriately with peers, those sorts of things. What we're really probably talking about are things like, and these are actual examples that we took from different teams that we worked with, a couple of them, I think, in my clinical work. I took a couple of these from it, but to have money, to have a paycheck, to live in an apartment, to get a job, I specifically remember a client who just wanted a driver's license. Getting a car was a little bit much, but getting a driver's license, there was something about that that just meant that they had made it. So if I had worked on, let's say, understanding my mental illness, or understanding the importance of my medication, when my client wanted to get a driver's license, we would be mismatched, like we would be butting heads a little bit. And so trying to connect getting a driver's license and the sorts of things that I can help him with to make it to the point where he could get his driver's license, that's where the engagement and services comes in. And so I've just listed a few other examples here that we've seen in terms of consumer goals. So, but just sort of really listening and trying to stay with the recovery goals of the clients is what we're after here. So I think I had mentioned before, assessment is a big part of it. So getting to know the person, getting to know their family. I think that's another key aspect of many of the evidence-based practices, sort of pushing ahead here to some of that, is that we need to really think about the consumer and their entire social network as the holistic aspect of the client, and really understanding how to engage them, because the folks in a consumer social network, whether it's a family member who knows a lot about mental illness and can be an advocate and be a part of that therapeutic relationship, or if it's someone who is not particularly helpful in the beginning, they don't understand mental illness, they are, they're serving as barriers to care rather than help, that then we can get to know that in this consumer's constellation of what they're bringing to the table, once we get to know where that social network is relative to the person, and get a good assessment of that, then it helps us to sort of conceptualize our next steps and what we need to do with those folks. And then, of course, once we get to know the person, we know what their recovery goals are. The other thing that comes up a lot of times, especially in, probably less so in terms of 50-minute CBT sessions where it's psychotherapy, traditional psychotherapy, but thinking about other intensive community mental health services, that really identifying and addressing the most basic pressing needs and sort of prioritizing them higher in what we're doing. So for instance, we may have had someone referred to us for their severe anxiety and functional limitations. But then we find out that their most basic needs, let's say they're out of food, and they need to go to the food pantry, or they need to get signed up for food stamps or things like that. So even though that's not something that we see as the quintessential core need, just being able to understand that those are the basic needs that they are most concerned about up front, and sort of getting those out of the way and addressing those, and not sort of relegating them to a secondary position in what we're doing with the consumer, really helps to engage that consumer in our care. So they're just basic needs that I think are going to be really important in order for them to really focus on their CBT for anxiety, for instance. They're going to be in a mindset to really be able to focus on that therapy session with you if you've heard them and tried to take some steps, even if it's not you taking them to the food pantry, but you can refer them to someone else who can help them to take care of that is an important piece of the formula there. And just, I think, as I mentioned before, really thinking about engagement as not just something that happens when you are first assigned a consumer, but something I think about engagement as just a part of a relationship and a strong relationship, that it's something that really has to be maintained over time, that we're going to tailor the sorts of things we do to the person in front of us and the goals that they have. We're going to continue to be patient when things that we are hoping changes that happen for the consumer happen. Maybe they don't happen at the pace that we're really comfortable with. Try to be hopeful, try to be persistent. And that's how we build trust with folks. Following through when we say that we'll do something. So, going back to the example on the last slide, that if someone has said that they really need food and that that's their biggest concern right now, making sure that if we say we're going to refer someone, let's make sure that we actually execute that referral as quickly as we can. Because then they see by your actions that you are really there for them and you're listening to them. And then I've got this last part, be there when things get bad, underlined. And in my earlier life, I worked at Threshold. So it's a psychiatric rehab center in Chicago. And I worked with John Fallon there. So he's since moved on from Thresholds. I think he's with Corporation for Supported Housing. But he ran the forensic assertive community treatment team. So he worked with a lot of consumers that were in and out of Cook County Jail all the time. And I remember one of our projects, I was doing interviews with consumers, and I interviewed this man who had just come out of Cook County Jail again, and he was in, temporary housing, which he was very grateful for because I think he had been homeless before he went into the jail. And he said, John Fallon has always been there for me, even at my worst. He's always there. He would talk about how John would pick him up at Cook County Jail, like not just wait for him to be, to be released and make it to John at the clinic, but he would go and pick him up. And that's the nature of that service. I realize not every program is set up for that, but he said that just after so many times of John not giving up on him when he thought for sure John would give up on him, that he knew that he needed to make a change. And eventually, John told the story of how this guy got better. He actually would give talks about this consumer would give talks about his transformation. I don't remember if he ever became a peer, but something akin to that. But he was in and out of the jail dozens and dozens and dozens of times. And just that persistence and that follow through. And, I'm sure if you talk to John Fallon, of course he was frustrated every now and then. But just knowing that someone was going to be there to pick him up was extremely important. And I love this Maya Angelou quote as well. So people forget what we say, they'll even forget what we did, but they'll never forget how you made them feel. And I think that is so essential, especially when we're talking about severe mental illness, people who go through life with just being bombarded by stigma and people telling them they can't and they won't, and how bad things get. And so to have hope, to be there for people and as they continue to struggle, maybe they do well and then they backslide. And so that consistency is just really important. So this should not be surprising to you. So, a lot of what I'm talking about, we're really talking about having a stage-wise mindset for how we want to help consumers. So thinking about, are they in pre-contemplation where they don't even see that there's a problem? Are they in contemplation where, boy, something seems off, but they're not really sure what it is. They're not really even sure that they want to make any changes yet. But, they would like to see the bad things go away. They're not really sure they want to do the things that they need to do to get rid of those bad things. And then the person who's in preparation, where they're actually considering what steps they might take, sort of weighing the pros and cons in their own head on whether it's worth an action. And then there are the people that are squarely in action. I think I look back to your comments here, people that are really ready to take action, they participate, they do their homework, they keep their appointments, they're showing up. They're punctual, they're actively working on their goals. Like what you're describing there, it's certainly people that are in that active stage. That's our goal, to get folks there. And then maintenance, after they've made change, being able to keep those changes up. So the big thing here to think about with engagement is where it can all fall apart. And I'm sure you're all gonna to guess it, but it all falls apart when where you are as a clinician is in action, but yet someone comes to you and maybe they're only in contemplation, or maybe they've crept up into preparation. So that's where it's just very difficult for you to engage the person if you're ready to go forward with the therapy sessions and they're really trying to decide whether or not these big changes that they need to make are really worth it to them. And so being able to take a step back and think about how you might help that person is going to help you to stay engaged with them. And then obviously, these graphics crack me up sometimes. So a lot of times engagement falls apart when we're not matched up with the stage that the client is at. So I know you've heard a lot about these sorts of things in the past. So hopefully this is not new news to you, but maybe thinking about it in the context of engagement is a little bit helpful. All right, so I'm going to see if you guys are still awake here. And I'm going to have another poll question here. Let me flash it up here. I think this poll question is on here. Okay. Oh, yes, it is. All right. How long did it take you to engage clients? Think of your last tough customer. How long did it take you to engage that client? You see this? Oh, can you not see the poll? No. Okay. Good. Let me go back. Hold on. Maybe I didn't hit relaunch. Relaunching will clear. Yes, I want you to do that. Oh, here we go. Sorry about that, folks. Thank you to all of the nopes. I appreciate you guys. All right, the last tough customer. How long did it take you to engage them? Days, weeks, months, years? I got 19 of 34 responding, 21. I'll wait just a couple more seconds in case anybody else wants to respond. It's looking like months is in the lead. Weeks is catching up. All right, I'm going to go ahead and end the poll now and share the results. Maybe I shared, maybe weeks would have caught up with months if I had waited a few more seconds, but it looks like weeks or months it takes most of us. So it's definitely not going to be days. So I think we get from this that it's just not an instantaneous process, right? Like engagement can take a while. So all the things we're talking about now, it can certainly be, you might have to sort of try these try these tools, try this mindset, and then keep trying it to make sure that you're sort of perfecting what it is that you're doing to try to really engage this person into care. Right. So predominantly weeks or months. So what do you do during that time? So thinking back to the stages, I hope that everyone has been to a motivational interviewing training. This is not a motivational interviewing training, but I just sort of want to highlight how motivational enhancement styles of communication can really help us when people come to us not really ready to engage in the hard work. Maybe there's still those folks that are wondering how big of a problem their mental health issues really are, or how much they're really ready to stop drinking or give up their marijuana to be live a clean and sober life, for instance. So thinking about motivational enhancement, like we really think of it as a way of communicating with our clients that really helps them to explore their ambivalence about a change that they may or may not want to make, and then resolving that ambivalence in some way. So sometimes people may not have much ambivalence. They may not see a problem with, and just I'll use cigarette smoking, for instance, as a behavior that someone might be trying, they might be referred to you for cigarette smoking cessation. So they may come to you not really even thinking that smoking is a problem. And so when that's the case, we really want them to explore, do they have any ambivalence about that? Maybe the health consequences or what it does to their family dynamics with their kids is something they are willing to explore. And maybe their ambivalence will increase during the course of you having these discussions with them, and then eventually we're hoping, resolving ambivalence towards really taking those steps to make the changes that they need to make. But really, if we think about motivational enhancement really as a way of communicating with people, of being with them and for them, and really trying to get that change talk. And I just think about motivational interviewing, that it's a journey, that it is not necessarily, I think it's very difficult to do, but that we're trying to search for the client's change talk, not the change talk that we would like to insert for them as the experts in our field. And I think that's why in motivational enhancement is so difficult for skilled clinicians, is you've seen this 1,000 times. The changes that the person needs to make. And it would be so much simpler if they would just be able to launch into that really quickly. But that's not how people change. I mean, people change for the long term when they decide and they have reasons to change. It's not because we recommend it, and it's not that we wouldn't, I always think about motivational enhancement. We only use it for certain stages. I think it's particularly relevant in the engagement process with our consumers, and maybe a little less relevant as people get into the active stages, because they are asking for your advice in those stages. So when we think about motivational interviewing, we're thinking about expressing empathy, really listening, skillful reflective listening. We think about developing discrepancy, thinking about where they want to be and where they are, and what is the discrepancy between the two. We really expect resistance and we roll with it. We try not to argue. We take resistance as a sign that maybe we need to switch tacks a little bit, and that's what our next step is. Not that we should press harder. It's that we should come at things from a different direction, or maybe change our perspective. And then to support self-efficacy, really to give people the confidence that they can make changes. So what MI is not, I always think this is helpful. I love to put contrasts up on things because what it isn't, I think of me and my teenage daughter right now. This is where I get a lot of my examples from. You should change because that's not MI. It's important for you to change because that's not MI. If you don't change, this will happen. That's not MI. You can make the change. Here's how you make the change. Here's what I want you to do. That's not MI. It's not that if a client asked you for advice, you wouldn't do that, but these are not typically for the people that are earlier stages of change. They're not really sure that they want to make these changes. This is what it is. And then I've got some pitfalls to avoid, rapid fire questions and answers, sort of focusing on something a little too early or labeling it. I always say, save that for your notes. Just some pitfalls to avoid if we're going to focus on motivational techniques. And then, of course, the ORS techniques, and these really aren't specific to motivational enhancement, right? These are clinical interaction techniques that all of us should be really comfortable with. So, and I always say, don't pay any attention. This is just the acronym that works, but reflections are king, and a summary is the granddaddy of reflections. But to help us to remember, open-ended questions, we're not looking for yes, no answers, but how, why, tell me more, about what that sounds like. Affirmations that must be genuine. And I always say for people with SMI, they don't get affirmations very often. So like if you can give a genuine affirmation, it sounds like you really want to be a good mom and you are giving it your best shot. Like that is an example of an affirmation. And then reflections, of course, reflecting back the things that we are hearing from the client. Hopefully they could be simple. They can actually be empathic reflections where we're really sort of reflecting back the emotions or the feelings that we're hearing. They can be double-sided reflections where we sort of, maybe if they give us that ambivalence, we sort of reflect that back. It sounds like they're dealing with this, but then also this. It's just, these are tools to allow people, to allow the consumer to be heard. So I'm going to pause here. It's 12:48. We have another section to go through, but if you have particular thoughts or questions, feel free. I don't see any others in the chat, but I'm just going to pause in case somebody wanted to unmic. All right. I'm going to take that as a no, but feel free. I think I can see hands raised. If you do have one. All right. So we've talked about sort of the clinical skill sets like of an individual clinician interacting with a consumer that is presenting to them or their family members. So I know that at one point there were quite a few administrators that had signed up for this. So I think this could be helpful for administrators, this next section, but also for anyone else. So what are the structures and processes that are in different mental health programs that can really help to engage consumers? And so I'm using assertive community treatment as my example, but a lot of these components of assertive community treatment can be in other types of programs as well, other intensive community treatment programs, integrated dual disorders treatment, crisis response teams, homeless outreach teams. A lot of these can be in other types of services. So let's talk about ACT, or assertive community treatment, for a minute. You might recognize these principles. So assertive community treatment is really focused on consumers who do not engage in care. Like it's a team built for consumers who are not necessarily too compliant with traditional outpatient services. They're consumers who are hospitalized quite a bit, There are some ACT teams set up exclusively for consumers who are in and out of jail, people with comorbid substance use disorders, people who've had long-term psychiatric hospitalizations, helping them to really thrive in the community. It's actually, there have been meta-analyses where ACT is really good for homeless populations, just with the way the sort of wraparound structure is set up. Is really helpful. So the principles of ACT for those populations, it's really focused on assertive outreach and engagement mechanisms. So that's why I'm highlighting it here. Locus of contact in the community, really emphasizing minimal dropouts, that there's crisis contact availability when it comes up. The ACT team really takes a role in hospital admission and discharge planning. As I mentioned before, informal support contacts could be the family, could be other people that they live with or outside of the family that's in their social network, is a key part of the ACT model, really having contact with those folks, being assertive and getting the releases that we need to have in order to have those conversations with them, multidisciplinary teams, frequent intensive services. So we'll talk about these in the context of engagement a little bit more. So let's talk about these three. I've sort of put them on one slide if I, since a lot of them are related. But ACT and other services like ACT really focus on assertive engagement. Assertive outreach, meaning that we will go out on the street and we will find consumers that need our services. Thanks. We're creative in that outreach. We may, one of the teams that I've worked with, they're like, we haven't seen Joe, I'm making up the name, Joe in a while, but he usually panhandles out at the corner of X and X. So let's go out and see if we can find him. It's usually he does it later in the day. Can somebody swing by there and see if they find Joe? We also use legal mechanisms to engage clients. And now these, we have to be recovery oriented. In order to engage clients well. So we only use these when needed, but we pull these out when they really are needed to engage someone who is not doing well or at risk. So thinking about outpatient commitments and getting those orders, and I realize that looks different in different states, being the rep payee for clients, so that especially for clients with substance use disorders, that we can make the team being in charge of that money and giving money out in smaller amounts maybe is less triggering to a consumer that has a substance use disorder. And that's something you can work out with that consumer. And then having a lot of contact with parole, probation, if they're in a drug court or a treatment therapeutic court of some kind. And I always say, if someone goes into jail, I was just listening in on an ACT team meeting this morning, and somebody went to jail, and it's terrible, but the bright side is they actually know where this person is. This is a person who tends to disappear, not go to appointments. And so why not make the most of those, restrictions when you're in jail, or if you have court order contact. Typically ACT 75 to 80% of the contacts are in the community, not because we're trying to just make people jump through hoops, but because these are clients that don't necessarily come into the office. So we go to them rather than requiring that they come to us. And then we have that mindset where we really aim for no dropouts. We're not looking for people to drop out. We're trying to keep dropouts to a minimum. We're doing as much as we can to really engage them while we have them. And then we think about no-shows as a reason to rethink our efforts. ACT teams provide typically 24/7 crisis. You'll score different on the fidelity scale depending on if that phone call from the client or the client's family and a crisis contact comes to your team or to another part of your organization who forwards it to you. But generally, if a client is in crisis, if the landlord has a crisis, this is what comes up more often than anything. Clients with serious mental illness and they're paranoid, and accusing their neighbor of something that didn't happen. The landlord being able to call the ACT team and come out and serve that client who is decompensating is a great way for the team to really meet the needs and to keep someone engaged in care. Really taking the lead in coordinating hospital admissions and then coordinating the discharge planning is critical. And I highlighted on this slide the critical time intervention model, because I think that that's a model out of Columbia where we think about these sort of critical periods where consumers are really vulnerable to sort of dropping out of care or having really negative outcomes. And I think ACT and critical time intervention model really overlap, that they really honor these acute phases as periods where we really need to step up and do more than we typically would during those phases. And then I've talked a lot about family and significant others, really engaging them and giving them a voice in the treatment of this particular client and being advocates. And certainly, if we need to get a release, let's get a release then, so that we can actually have them as members of our team pursue that, advocate for that. I hope that everyone appreciates that the things that I have talked about today, whether client, just individual clinical interactions, or the sorts of services that I'm talking about now and program structures, you can't do this with 70 people on your case. There is a limit. I think that if you have 70 people on your caseload, then it is very difficult to engage them if they are resistant clients. If you have 70 people and they're all signing up for the service, that might be a little bit different. But I would say in community mental health, where we're typically serving people with more extensive, intensive needs, really keeping caseloads low. In ACT, it's 10 to 1 or fewer. Sharing caseloads. I think the shared caseload is really helpful on ACT, because there may be times when there's a tough customer, somebody who's really resistant, you're human, you're going to get frustrated, and then team members can actually rotate who goes to deliver the meds to that client, or who takes that client to court, or all of those things. And having that shared caseload really helps the team to sort of distribute the struggle when things are tough with certain consumers. And then obviously having the capacity to see clients, maybe earlier on when I talked about being creative, sometimes meeting with someone for an hour is beyond their capacity to pay attention. And so we have to do things a lot more quickly. So we might see them several times a week, as opposed to once every 2 or 3 weeks in a traditional therapy. And having plenty of time to really spend time developing skills, listening to them is a key piece of that. I would say no arbitrary time limits on services is a critical piece of the model, that we're not in a big hurry to graduate folks from our services. And that's quite a bit different from other service models or, other types of therapies. Having a range of different kinds of services integrated onto a single team. And I also think that this helps to having a supported employment person, having someone to help with housing, having a nurse on your team is certainly helpful. I'll mention different roles here in a second, but really helpful in helping that person to understand that they can get a lot of their needs met on the ACT team. So, I forgot to put this on a poll. So we don't have it on a poll, but if you want to write in the chat, of these ACT team roles, any that you feel, and I know there's people that are, maybe this is the first time they're hearing about ACT, but if you had to think about engagement, any of these roles that you think are more, might come out in the lead in your mind in terms of engaging consumers, maybe just type it in the chat if you have ideas. Oh yeah, I'm with you, Melinda. Absolutely. Housing specialist, peer recovery specialist. Thanks. All right. So I think the couple of you said peers, and that's definitely number one on my list. I mean, we know that peers are good at outreach and engagement, helping clients to really articulate their personal goals, advocating for them, offering hope and reassurance, helping them to sort of navigate the world. So I'm with you there. I'm going to go through these pretty quickly here. But I also think a lot of the other team members, I'm just going to mention a few. So the case manager, I think the case manager or skill specialist, depending on what state you're in and what Medicaid requires at the time, what you call yourselves, but these are the people that are probably having the most contact. They're spending a lot of time with the client, building relationships, seeing them in the community. So they really know the consumer best. So I think that is a key piece. And also on call in the event of crisis, that is something that can really help you to engage with folks. I think the specialists also play a big role. I have certainly seen nurses. Some clients, they don't really want to talk about their mental illness, but they'll tell you about this place on their toe that is bothering them. And they're willing to talk to the nurse about that. And I'm like, there you go. Your toe is in the door. But certainly I think nurses are a big way to really engage with clients, especially clients who don't necessarily want to focus on their mental health issues. Employment, I mean, having a job, or maybe the people aren't so hip on a job, but they certainly want a paycheck. And so that employment specialist is a way to sort of help connect your team to their goals. And then hopefully at some point they will want to work on other issues as well. Housing, somebody mentioned the housing specialist, absolutely, especially if you're dealing with a homeless individual, that having someone who can coordinate housing is enormous. And then the substance abuse specialist, being trained in motivational enhancement, hopefully knowing a lot about stages of change, whether it's related to substance abuse or not, is a critical role there and can really sort of influence the team. So just a couple more thoughts, and then we'll break out into small groups here. I think, yes. So thinking about ACT, I think a lot goes into our expectations. So in a program like ACT or other programs similar to ACT, we really go into that expecting our consumers maybe to be a little bit difficult to track down, that they're going to have trouble remembering appointments. They're going to avoid contact at times. We're going to, even when we go out into the community and knock on their door, they don't answer. And so then we knock on the window, we look out the back, to see if they're smoking on the back porch. Those sorts of things. So we have to go at it knowing that we may have to try a little bit harder on those teams. And I think that setting that expectation that this is our role, rather than feeling like it's a barrier, we consider that a part of why we're here. And so if you can reframe it, I think that's really helpful for engagement. Really conceptualizing when someone is disengaged, not that it's a personal assault on my schedule and screwing things up and screwing up my productivity. There's not any sort of intent for malice there. But disengagement is really about maybe unmanaged or undermanaged symptoms or underdeveloped skills. And so we just have to think about it a little bit differently. And then just the whole notion of the team concept. So I don't think you need to be an ACT team to maximize this. But if you are a part of a team, there will come a day when you lose your cool, when you are not patient, when you are not present, and it is completely understandable. But if you have a whole team to sort of help you out, to remind you, like if we start to talk negatively about a consumer, does everybody have the psychological safety on that team to speak up and say, oh, Angie, you must be having a bad day? But he goes through these patterns, things can look up, it's up to him, but we're going to be here to help him. Like, how do you help your team members sort of reframe these things? So those are the thoughts that go through my head when I think about engagement. So hopefully some of these things sound familiar, and you all have some of your own ideas that